Yes, ma'am.
Okay, great. Good morning, everyone, or good afternoon, good evening, wherever you are. It's really lovely to be here with you all. I'm presenting from the University of Washington. That's the picture of the main medical center and my office right now. So I'm here on the 5th floor of this tall building, and that is Lake Washington right there. I have no financial interest to disclose. So today we'll be talking about one of my favorite organs, the pancreas, and I want to thank the organizers of this remote teaching program for inviting me to talk about the pancreas. So for the first, we'll talk about the gross, we'll review the anatomy, we'll talk about the different types of resections, and really the meat of the talk is going to be on how to gross a Whipple resection. And also I will give you some sampling guidelines, and we can, at the end of this first part, I would like to invite Dr. Munita to give us her perspective. And then we'll go on to part 2, which is the microscopic anatomy or the normal histology of the pancreas. And we'll talk about both components, the exocrine and the endocrine components. All right, so let's get into the grossing. So before we even begin grossing, it is really important to get a plan together. First, look at the patient history. What is the exact procedure? What was the indication? Is this for curative intent or was this for palliative intent? So as you know, with pancreas, it's Whipple resection is often done for pancreatic ductal adenocarcinoma. And sometimes, we don't just do it to cure the disease. We also do it for palliative intent when they present with obstructive jaundice. And always look at the prior pathology. Do they have an FNA or do they have tissue diagnosis? And what about the preoperative therapy? Have they had any neoadjuvant chemotherapy? And also the radiology is very important. And as always, this is not particular to pancreas, but you want to check your materials, make sure what is on the requisition is the specimen received. Check the operative notes. Was there any unusual anatomy? Was there maybe any aberrant vasculature? Or was there, is there a minor or an accessory pancreatic duct? And once you have all of this background information, then think about the anatomy, understand your specimen, and formulate the grossing plan. And with these specimens, it's always a good idea to consult if necessary, because remember, grossing is an irreversible step, right? When we, you can always take more tissue, we can always do IHC, but when it comes to grossing, once you cut up a specimen, really there's no way to put it back. So ask as many questions as is necessary. So let's review the anatomy of the pancreas. So the pancreas is a mostly retroperitoneal organ, and it lies in front of the aorta and the IVC, and it lies within, sort of nestled within the C, D2 and D3 of the duodenum. And remember that only the anterior surface, so what we're looking at right here, this is covered by peritoneum, so it has a serosa. And there actually is not there is connective tissue that surrounds the pancreas, but it's not a distinct or a true capsule. And what we want to identify are the bile duct and the pancreatic duct. So both of them come and join at the ampulla, and it opens up in via the major papilla or the papilla of Vater. And sometimes in about 5 to 10% of people, you can have an accessory or a minor pancreatic duct, or the duct of Santorini. And usually the minor duct opens up about 2 centimeters proximal to the major papilla. And so the anatomic subcompartments, so mainly it's the head, neck, body, and tail. And the uncinate process is actually part of the head. It's just an extension of the head. And these compartments are designated based on their relationship to the superior mesenteric vessels. So the neck is anterior to the superior mesenteric vein and artery, and the head lies to the right of the superior mesenteric vessels, the uncinate curves backward and is posterior to the vessels. And the body, which is the main part of the pancreas, is to the left of the superior mesenteric vessels. And the tail is typically not as substantial. It's a few centimeters within the splenorenal ligament at the splenic hilum. And the tail is the only intraperitoneal part of the pancreas. So the head, neck, and body are retroperitoneal. And being retroperitoneal, this means that our imaging, your CT, MRI, is not very good at identifying too many details of the pancreas because it's tucked in the retroperitoneal region. And also, when we look at the anatomy, we want to think about the Vetterian system or the duct system. So the pancreatic duct, the main pancreatic duct, and its side branches, and also the location of your tumor. Because based on where the tumor is, you can narrow your differential diagnosis. So, for example, ductal adenocarcinoma is predominantly in the head, as is acinar cell carcinoma. And however, on the other hand, mucinous cystic neoplasm and neuroendocrine tumors are predominantly in the body or the tail. Serous cystadenoma and solid pseudopapillary neoplasm can arise anywhere. And also, at the time of grossing, think about, is the duct involved? So here in this cartoon right here, we see the main pancreatic duct. And here the side branches are also depicted. And so here you can see that these two lesions, so one here in the head and one here in the body, these are associated or arise from the ductal system. And so these are and so when you know that it's associated with the ductal system, then immediately first on your differential is intraductal papillary mucinous neoplasm. And so here, that is what this MRCP and MRI are showing, the duct system. And here on top, if you look at these pictures, here we have a CT and an MRI. These are showing that the lesions or the tumors do not involve the duct system. So, examples of this are serous cystadenoma and mucinous cystic neoplasms. So think about, okay, where in the pancreas is it? Head, neck, body, tail, and does it involve the duct system? So moving on to our common resection types. So here we have a Whipple resection. Whipple resection is, can be a classic, which includes partial gastrectomy, or it can be pylorus preserving, where we have only intestinal margins. So the pylorus is preserved in the patient. And so pylorus preserving Whipple is sort of in vogue in the recent times, but studies are showing that when it comes to morbidity, it really doesn't make too much of a difference when it is pylorus preserving. So you might get either a classic or a pylorus. And here on the right side, we have a distal pancreatic resection, which is the more common resection of these two types. And so you can see that it primarily involves the body and the tail. And most often you'll also have the spleen, because we're also removing all of this vasculature. So the spleen also comes out along with the pancreas, the body and the tail of the pancreas. So let's actually talk about the distal pancreatectomy first. So when it comes to the distal pancreatectomy, really the only margin that we're concerned with is the parenchymal resection margin. So we have one margin to think about, and it is also a good idea to mention involvement of the neoplasm of the surfaces, the anterior and posterior surfaces. So the parenchymal resection margin is taken en face, and it can be taken perpendicular if the tumor is close to the margin. And of course, as with any other resection, you would note the size and distance to the relevant margin. If the splenic vein is present, so quite often you get the splenic, you will get the splenic vessels. So it's a good idea to evaluate the vein and evaluate for thrombosis and tumor. and also getting your vascular margins is a good idea. And typically, you would submit lesions if it is beyond within 5 centimeters. And particularly, we want to sample the more solid and the indurated areas. Okay, so going on to the main part of the talk, which is the Whipple resection. So as we said, it can be a classic or it can be pylorus preserving. So here in this picture, we're seeing the distal stomach with the pylorus. Here's the first part of the duodenum, D2, which hugs the pancreas, and here we have D3. And so you really have the head with the uncinate process and the neck of the pancreas. Sometimes you might get a little bit of the body depending on how the vasculature was involved. So, but these are the components of your Whipple resection. So this is what it looks like in situ. So this is what we're removing. Sometimes you also get a gallbladder along with the cystic duct, along with the, and not just the common bile duct. And for the anastomoses, so the pancreas opens up directly into the small bowel. The bile duct opens up directly into the small bowel, and the stomach opens up into the small bowel as well. So you have a pancreatico-jejunal, gastrojejunal, and the bile duct to the duodenum or small bowel again. Okay, so the thing that makes the Whipple quite complicated is that we have many margins and many surfaces to think about. So when you look at this picture right here, think about like what the margins are. And so these margins and surfaces can be different in different locations. So it's always a good idea to talk to your surgical colleagues and find out what they're interested in. Before you gross the specimen. So have a good idea of what the institutional policy is. So what might be happening in my institution may not be the same as what is happening in your institution. So, as in all of pathology, really, we are catering to the patient and the surgical colleagues. So it's a good idea to understand what information they need. So I'll tell you about my experience. So at the University of Washington and predominantly really in North America, we follow the CAP guidelines. And so we have the bile duct margin shown in green here. We have the pancreatic neck with the pancreatic duct margin. And we have the uncinate margin. So the uncinate is taken as a chunky section, like a chunky enfas, and then it is perpendicularly bread-loafed. And of course, we have our intestinal margin. So proximal, sometimes it's duodenal, sometimes it's gastric, and then at the distal end, you'll have another small bowel margin. So these three margins, common bile duct, pancreatic neck, and the uncinate, are pretty much everyone agrees across the globe. So this is the CAP and the Royal College of Pathologists, and what most of your institutions would be following as well. So these margins, out of these two, make note of the fact that CBD margin and the pancreatic neck margin are transected margins. So the surgeon cuts it off, cauterizes it. On the other hand, the uncinate is not really transected, but is dissected. So it's a dissected margin. Now, the other surfaces or margins that are important are the vascular groove and the anterior and posterior surface. The vascular groove is the area that abuts the superior mesenteric vessels. And so the Royal College of Pathologists, so in the UK and in Asia, for the most part, it is considered a margin, but here we treat it as a surface. And the anterior and posterior surfaces are considered margins by the Royal College of Pathologists, but the CAP considers them as surfaces. So I'm pointing out these differences to you because there is a lack of consensus on what truly constitutes the margins and the surfaces. But regardless of the name we give it, whether it's a margin or a surface, the primary question you should ask yourself is, okay, what do the surgeons need? What does the patient need for treatment, and decide how you want to report it. Okay, so talking about ways to section the pancreas. So there are two common ways of doing it. I would say overall, the more common method is the axial method, which is axial slicing perpendicular to the long axis of the duodenum. And the other method, which is slightly more complicated and which is unfortunately or fortunately the way we do things on this side, is the bivalving method, where the pancreas is opened up like the leaves of a book, pages of a book, and you get two halves of the pancreas, and it is sliced along the common bile duct and the pancreatic duct. So here, if you look at this picture here, you can see the folds of the duodenum right there. Here you can see the tan yellow pancreas. And then here you see this large structure here, which is opened up. That lumen is the bile duct lumen. Typically, it's the largest lumen. And then we also have the pancreatic duct right here, which is typically small. So you're seeing the pancreatic duct and the bile duct meet at the ampulla or into the major papilla. So when you look at it this way, it offers a different perspective on the anatomic structure. And so it really depends on what your institutional preference is. There is no gold standard really, although in North America, it is predominantly, the predominant method is the bivalving method, and on the other side, it is predominantly axial slicing. So let's talk about the pros and cons of these two methods. So when it comes to axial slicing, again, so we're slicing it along the long axis, and we're essentially bread loafing the entire specimen. So with each section, you're going to see the duodenum, you're going to see the pancreatic tissue along with the bile duct and the pancreatic duct. And here do you see this like vague lesion here? So that is the tumor there. So you see the relationship of the tumor to the various margins. And this method is better for evaluating the tumor extent and margins. And one of the cons is that it can overestimate the lymph node count. So as you can imagine here, we have in the peripancreatic tissue, we have lymph nodes. So if you had a lymph node that was, say 6 millimeters, you would see it in this slice and you would see it in this slice. And sometimes it can be overcounted as 2 lymph nodes when it's really 1 lymph node. Okay, so moving on. So the bivalving along the pancreatic duct and the CBD. So as we said, this is longitudinal sectioning. So you have 2 pages of an open book. And this is a better view of the duct system. And this is better when you're thinking about intraductal neoplasms like an IPMN or any other or invasive carcinoma arising from an IPMN. And it is also good for assessing the primary site. So remember that the Whipple resection, you can do it for not just for pancreatic neoplasms, but also remember we have the bile duct coming in here. So from the bile duct, you get cholangiocarcinoma, right? So it's not just for pancreas, but also for cholangiocarcinoma, and we have the ampulla here. So even for duodenal and ampullary carcinomas. So the primary site can be many different, it can be different origins. And depending on what we call it, the prognosis and the treatment options are vary for the patient. And of course, the pancreatic duct, the pancreatic origin has the worst prognosis of all of these, and ampullary tend to do better. So that's why it's so important to assess the primary site. And So while this is good for assessing the primary site, it can be difficult to evaluate the margins. And this method, because we are manually taking out the peripancreatic fat, can undersample the lymph nodes. So here in this picture, we see ampullary neoplasms. It can be subclassified into those involving primarily the pancreatic duct. So here we have a papillary neoplasm primarily involving the duct. Here we have, again, it is involving the duct, but this is not really papillary. And then here you see that this is ampullary duodenal. So it involves the ampulla and it involves the duodenum. And we also have a NOS category, or not otherwise specified, when it doesn't fall into these three categories. Okay, so let's talk about orientation. So when we get the specimen, the first thing I like to do is to think about where the anterior and posterior surface is. So these are fixed sections. So these are formalin fixed sections. And so sometimes the formalin fixation can alter the anatomy. So it's always a good idea to do these, ink the specimen before you do the formalin fixation. So the anterior surface, this here on the left side, is more sort of lumpy bumpy. It is more convex. It is irregular. It has more fat. And then here on the other side, on the right, you'll notice that the posterior surface is flat, and also it is serosalized. It's smoother. I'm sorry, not serosalized, but just smoother and flatter. And so it is a good idea to ink these surfaces. And here also notice on the posterior side, it's easier to identify the bile duct margin right there. And so when you flip over the specimen, so placing the pancreas, when the pancreas is sitting on top of the duodenum, the easiest structure for me to identify is the vascular groove. So here, if you look at this trapezoid structure, you see that it is quite smooth and also a little bit concave. And that is because this is the region where the superior mesenteric vessels and the portal vein are present. And so this is the vascular groove. And then here you'll see on a larger ragged surface. And so this is the dissected margin of the uncinate. And then here we have on the other side, it's a smaller, more flat pancreatic neck margin. And the uncinate always has a lot more fat, which is why it looks quite irregular. So once you identify the vascular groove, it's important to ink these margins. And again, in this trapezoid here, it's a close-up view here in the uncinate on the superior aspect of the uncinate. Here, this is where you'll find the bile duct. And in the posterior neck, you see the pancreatic duct orifice. And typically, it's smaller than the bile duct opening. And sometimes the bile duct also might be stented. And depending on what type of stent, if it is, if it is a metal stent, it is a good idea to remove it if it is present. So these margins are inked. And then we move on to the uncinate. So the uncinate, once it is inked, we are going to bread loaf it. So we take a thick section, about like a centimeter or so, and then it is bread loafed so that we see more of the margin. And so once these main margins are inked, you can also take your other margins, which is the proximal and distal, proximal gastric or intestinal, and distal duodenal. And the tumor is typically going to be far away from these, so it's not necessary to submit the entire thing, but just representative en face is enough. And the CBD is submitted entirely, pancreatic neck entirely, and the uncinate is also submitted entirely. But like we noted, these are perpendicular sections of the uncinate. So the reason we do we want to look at a lot of the uncinate on microscopy is because the uncinate has a lot of fat, and wherever you have fat, you also have lymph nodes. And our imaging is not very good at identifying lymph node mets in these small lymph nodes. So that is why when we do the pathologic examination, we want to make sure that we are sampling and evaluating all of these uncinate peripancreatic lymph nodes. Okay, so this picture here, we've opened up the duodenum on the anti-pancreatic side. So here's the pancreas, so you want to open it on the opposite side. And here you can see a duct through the common bile duct, which is here we have one star here, this probe, and then this probe with the 2 stars, that is the pancreatic duct. And then here you can also see this plastic stent coming out of the pancreatic duct. So what we're going to do is we are going to bivalve or open it up along this plane. And so when you probe through the pancreatic duct and the common bile duct, it's going to come out. Sometimes it doesn't come out because we have obstruction with the tumor, but when it does come out, it's going to come out through the major papilla. And so here in the duodenal opening, you can see it kind of looks like a little bump. And you want to really, on gross examination, really look at the texture, the color of the mucosa surrounding it. Because if you see carcinoma here, and so then it comes under the category of ampullary neoplasms. And sometimes, like we talked about earlier, in a minority of people, 5 to 10%, they can have an accessory or the duct of Santorini that opens up through the minor papilla, which is usually it is anterior and proximal to the major papilla. And once again, reviewing the ampullary carcinomas, it can be intraductal, either associated with a papillary neoplasm or just not a papillary neoplasm, and then you can have ampullary duodenal. So we've probed this and we've examined the ampulla, and so now what we're going to do is remove the peripancreatic fat on the anterior surface and posterior surface, and the pat is peeled off, and then we bivalve the pancreas. And so whenever we open up when we're doing the bivalving, it's important to proceed slowly, and as you keep cutting, you want to check that you're staying within the plane. So here in this cut, for example, you can see that it's following this probe here. This is the probe through the pancreatic duct. And then this probe here, so here you can see this blue stent. Do you see how this blade is not going through that? Do you see the lumen of the pancreatic, the bile duct stops here? So here the grosser would have to take out the blade and try and find the plane again. So it's important to keep checking with every cut to stay within the plane. Okay, so in an ideal scenario, this is what it would look like. So here, the larger structure, this is the bile duct, and then this smaller structure here, this is the pancreatic duct. And so here, you can see there is a tumor. And it is at this point that the specimen is fixed. So yellow, again, showing the bile duct, and green showing the pancreatic duct. And one of the important sections that we have to take is this ampulla section right here. So again, bile duct, pancreatic duct opening into the ampulla. And again, this is important because we want to identify the location. So for example, if most of the tumor is in this area where the red is, that would be a pancreatic origin. If most of the tumor is surrounding the bile duct and you have in situ or biliary intraepithelial neoplasia, then you would call it a cholangiocarcinoma. On the other hand, if the main tumor is in the ampulla and in the duodenum, and you have in situ neoplasm or dysplasia of the duodenum, then you can call it a ampullary carcinoma. So this particular slice right here is going to give you a good understanding of what the primary site is. Okay, so how much of the tumor should we submit? So the T stage is size dependent, not peripancreatic extent. So before the 8th edition of the AJCC, which came out in 2018, before that, the T stage was dependent on the extent of the tumor. So does it go into the peripancreatic tissue? But since 2018, we've switched to size for the T staging. So because this is size dependent, it's important to get an accurate size determination. So what we want to do is get consecutive or serial sections to determine the microscopic span. Because pancreatic cancer has a lot of, is the poster child for desmoplasia, right, for desmoplastic reaction. So here what you're looking at, and it feels firm like a carcinoma, but most of it might actually just be desmoplasia. So we don't know here if this tumor measures 5 centimeters grossly. We don't know if inside we have cancer or not. So this is why we do the microscopic span. So for example, here, we have this cartoon here. The top cartoon here shows the tumor bed in light gray. And so when you submit the whole thing on histology, you realize that only we have a tiny bit, less than a centimeter, that is actually the viable carcinoma. On the other hand, if you look at this middle picture here, you have lots of viable carcinoma, and it's about the size of what we measured grossly. On the other hand, it's also possible to have a scenario where you have tumor extending beyond what we can see with our naked eye. And so here, the tumor size would actually be greater than what you see on the macroscopic examination. So sometimes, but sometimes it's not possible for us to estimate this accurately. So if it involves the vasculature, so if it involves the celiac axis, the SMA, or the hepatic artery, then it would automatically go to a T4 stage, in which case you don't really need to worry about the sizing. So this is why it's important to think about the before grossing, having all of this information. So on imaging, if you knew that it actually involves the vasculature, then you don't have to worry so much about getting an accurate tumor size when you gross the specimen. Okay, so the goal of surgery is to achieve negative margins. So, we also call it R0 resection. So most of oncologic surgery, they really want negative margins. And if you have a positive margin, it's correlated with poor outcomes. So for pancreas, the positive margin, or the R1 rate, it has a wide range, between 20 to 80%. So what does that tell us? That tells us that we don't have the right definition for margin development, and there's a lack of standard grossing protocol. And pancreatic cancer is on the rise. So by the end of the decade, so by 2030, pancreatic cancer is going to become one of the top 5 cancers in North America, and globally also it is on the rise. So we really should get consensus on how to gross these specimens accurately. And so for whatever it's worth, the positive margins are higher with axial slicing. So this actually tells us that margin assessment is better with axial slicing. And right now, we don't really have studies comparing both grossing methods. And so hopefully in the future, this is something that will be done. Okay, so let's recap about the gross evaluation. So there is no standard grossing protocol. The two types of methods are bivalving along the pancreatic duct and the common bile duct, or axial slicing. Both of them have their pros and cons, and it would depend on what your surgeons and oncologists need. And typically on North America, we follow bivalving, and on the other side, it's axial slicing. And what is important while grossing is to get consecutive serial sections to determine the microscopic span. Okay, I'm just going to stop here quickly to ask Dr. Munita for her perspective on grossing pancreas.
Yeah, thank you so much, Dr. Annie. It was a delight to listen to you. Your figures were very beautiful, and the way you explained everything beautifully, I really enjoyed it. And you touched upon all the important aspects. And here, I work in a cancer center, and it is a high volume cancer center. We do a lot of pancreatic resections, about on an average about 100 a month. And in this part of the world, we have more of ampulla. So we come across a lot of ampullary primaries rather than the pancreatic, also because the pancreatic hardly make it to the operating table. But we have a whole bulk of, so in a month, about 60 to 80 ampullary primaries are done, and much less pancreatic primaries. And now we get mostly post-neoadjuvant. So grossing of pancreas is it's a specimen that is not very commonly dealt by the residents. So it's a specimen that, and it needs a lot of familiarity with the anatomy, and it should be done under supervision initially. And you need to be very familiar with the anatomy of that region. And also, it's good to have intraoperative notes to see whether vessels were also part of the resection. So sometimes they can be advanced cancers, like in our cases, we get some part of the vein also resected. So always I ask my residents to check the operative notes. Sometimes there will be a very small part of the superior mesenteric vein which will be there, and it may be completely missed if we don't check the notes, or if we don't look at the specimen carefully. And then there is the emphasis on epicenter. So one of the things that I am very particular is the thing that can be only decided or mostly decided is about the tumor epicenter is by the grosser, because only they can tell you where the bulk of the tumor is, because the TNM staging of these three cancers, which can be in that small site, their TNM staging is different. So CBD cancer, primary pancreatic cancer, and the ampullary cancers, they have different TNM staging systems. So if we are reliant on the grosser's observation where the bulk of the tumor is, and in our setting, majority of the cases are in the ampulla. And because it's a small site, it tends to involve CBD as well as the pancreatic parenchyma. So the input given by the grosser is extremely important, and it has to be corroborated on microscopy. And it is for the pathologist to determine where is the primary. Is it an ampullary primary? Is it a CBD going into the ampulla and pancreas? Or is it a primary pancreatic head cancer going and involving secondarily the ampulla and because then that is how the staging will pan out. And we do axial slicing here. For the last 10 years, we have been doing axial slicing because our surgeons wanted all the surfaces, all the margins. So and it is easier, and ours is primarily a pancreatic, ours is primarily an oncology center. So we are mostly concerned with the margins. So we do the serial slicing, bread loafing, and axial, and that helps in margin assessment better. And there's a lot of skill required in bivalving. I remember in my grossing days, I could never get it in the same plane. And when I would get it, then it would be great because it gives a very beautiful, especially if it is a cystic or an IPMN or a cystic neoplasm, then it gives very good correlation with the ductal system. And so that is how we do it. And lymph node assessment, I make sure I'm very particular about the lymph node yield. So I try to emphasize we regrows. And because we do axial slicing, the counting has to be, you have to uh, see that you're not overcounting, like you mentioned. And if the nodes are less, then we go back and do the orange peel remaining part of the whatever, especially around the CBD and the SMA area, where we get to find those nodes. And about the veins, I make sure that the veins are not missed. If the vein is included and if the whole segment is included, then the proximal and the distal cut margin of the vein is included. And otherwise, sometimes it is just a small segment, which then we have to be careful about the vein margins. So that's it. That's how we grows here. And about the tumor size, again, like you mentioned, it is, especially after neoadjuvant therapy, it can be very difficult to assess the tumor size because the pancreatic cancer staging is dependent on tumor size. So measurement, just the way you mentioned, requires a lot of proactive microscopic and gross correlation. So thank you very much for this part. Was excellent.
Of
I
course.
really enjoyed it.
Yeah, I think one of the, I'm just speculating here, but I think like maybe one of the reasons why we get more of the, we get a lot of cystic lesions. We get a lot of, as you know, the IPMNs are mostly incidentalomas. And so I feel like we see a lot more of the cystic lesions, and maybe because patients like get scoped for
Imaging.
endoscopy
Yeah.
and things like that, maybe the ampullary polyps, we also get a lot of ampullary tubular adenomas and polyps. So maybe like we're taking it out in the early stage for the ampulla,
Yes.
and the
Yes.
pancreatic lesions, like we see a lot more of the cystic, so we tend to favor the bivalve.
Yes. Yes.
Yeah.
Our IPMNs are much lower, and cystic much lower. I think some part of it is that the patients for pancreatic cancer don't make it to the OT,
Right.
but
Yeah.
the incidence is somewhere between the west and
Yes.
east.
Yeah.
So the incidence is slightly higher for ampullary.
Yeah.
And
Yeah. Thank you so much. I'm sorry. Yes, I will go ahead and use the laser
yes,
pointer.
please. Sorry, I did a lot.
Yes.
Please go ahead.
Yeah, please feel free to interrupt. Okay.
Ma'am, there are few questions in
Yes.
the chat box.
Yeah. So
Are there minimum number of lymph nodes to be submitted?
there is no exact number, like, in the colon we say 12, in the esophagus we say 16, but for the pancreas there is no number as such. We just say all lymph nodes, and we typically submit all of the peripancreatic fat, not just for assessment of lymph nodes, but also for, sometimes you see cancer just sitting in the fat, right? So that would count as peripancreatic extent. So also to document peripancreatic extent, we submit the peripancreatic fat almost entirely. So there's no minimum number. And also the other thing that is also a variable is the neoadjuvant treatment. So now a lot of our cancers that we evaluate are neoadjuvant therapy, and in that setting we have no data about the number of lymph nodes. So I would just say, submit all lymph nodes, whatever you can find.
Okay, ma'am. And is it the CBD per se or the common hepatic duct to the those for resected margin?
Yeah. So typically we get the CBD. Sometimes you might, we might also get along with the gallbladder. Sometimes you get just a cystic duct margin. So it depends on what the type of resection is. So let me actually go back to my presentation. So if we go back to this anatomy slide here. So here we have the common bile duct. Here we have our cystic duct. So sometimes you might get it like cut over here. You might get another hepatic duct there. So it depends on where the surgeon has resected. Okay, so now let's move on to the 20 minutes or so. We'll talk about the normal histology. So The pancreas is quite a remarkable organ because it has a very significant exocrine function and a significant endocrine function. So it is a mixed exocrine and endocrine gland. And so here, as you can see in this cartoon, we can see these they look almost like a bunch of grapes. So we have these acini, which are the secretory glands.
Ma'am,
And
we can't see the slides.
oh, I'm sorry. Okay, how about now?
Yes, ma'am, it is visible.
Okay, and now you see the full screen?
Yes, ma'am.
Okay, great. And also let me make sure I have a laser pointer on. Okay.
Yes,
So
ma'am.
here, okay, can you see the screen now?
Yes, ma'am.
Okay. So what we're seeing here are these, the yellow is, these are the acini. And here in blue, what we're seeing are the ducts. So anytime you have a gland, you typically have any sort of gland, whether it's the mammary gland or the parotid gland, you have the acini that makes the secretions, and then you have a duct system that carries the secretions out. So the acini make the digestive enzymes, and it's actually the ductal epithelium that makes the bicarbonate. So your pancreatic juice is rich in digestive enzymes and bicarbonate, and you need that bicarbonate to neutralize the acidic contents coming from the stomach. And then so you can see that these digestive enzymes, these are the digestive enzymes. You can see these little granules here at the apical part of the cell, and they are packaged within zymogens or secretory vesicles, and they are not activated yet. So that's how in the normal state the pancreas doesn't digest itself. So this is what the histology looks like. You can see that we have these acini, which are these glandular structures. You typically don't see the lumen of the acini. That can be a little difficult to identify. And here in the center of this picture here, you can see cuboidal epithelium lined duct. And so the proenzyme, so we talked about how they're packaged as secretory vesicles, so they don't activate inside the gland. Proenzymes are activated in the small bowel by enterokinase. So the enterocytes secrete enterokinase, and that converts trypsinogen, trypsin, and trypsin activates all the other enzymes. So we have a number of enzymes, digestive enzymes. We have proteolytic enzymes, lipolytic enzymes, amylolytic enzymes, and nucleic acid breaking nucleolytic enzymes. So the trypsinogen is the sort of the main one that catalyzes, after its conversion to trypsin, catalyzes the activation of all of these other enzymes. Okay, so now the duct system, it's a series of ducts. So it goes from the smaller duct to the larger duct, eventually ending up as the main pancreatic duct. So it really begins with these centroacinar cells. So for example, here you see this, the acini, and these cells right here, these sort of almost stellate looking cells, which is at the center of the acini. So therefore the name centroacinar cells. That is the beginning of your duct. So here you can see centroacinar cells for this acinus. And for this acinus, here are the centroacinar cells. Same way for this. So these come together and form the intercalated duct. And intercalated ducts will join other lobules, lobular ducts known as the intralobular ducts. And then between the lobules of the pancreas, we have the interlobular ducts. So centroacinar, intercalated, and intralobular and interlobular ducts. And the interlobular ducts are the ones that feed into the main pancreatic duct. Sometimes you also have an accessory duct. So think of it as a bunch of grapes. So these grapes are your acini. And you see this like little stem here holding the grape, that is your intercalated duct. And then as it joins a bigger branch, that becomes your intralobular duct. And then many lobules come together. Those are your interlobular ducts. And this is the one that feeds into the main pancreatic duct. And now let's talk about the endocrine pancreas. So the endocrine pancreas are scattered within the parenchyma of the pancreas. So these are known as the islets of Langerhans. And they're very easy to identify because they're very pale staining compared to your very deep, beautiful purple of the acini. And notice how, the main difference between an exocrine and an endocrine organ is that exocrine has a duct system, endocrine, and it has local action. Endocrine, on the other hand, it does not have a duct system. So the secretions that it makes or the products are directly dumped into the vasculature. So it's highly vascular. So here you can see these capillaries here within the islets and surrounding the islets. So whatever secrete products that the islets are making directly enter into the systemic circulation, as opposed to exocrine, which is more local action. And the islets comprise only about 1 to 2% of the pancreas in adults, but in pediatric population, neonates, it's as high as 20%. And typically it has this sort of very compact oval appearance. Sometimes you can see just strands of neuroendocrine cells, and that's known as the diffuse pattern. But here what you're seeing, that's the most common type, the compact pattern. And so the types of cells that we have within the islets, so these are neuroendocrine cells, and these neuroendocrine cells, and we also have specific cell types. So beta cells, which secrete insulin, that's the most common type. Alpha cells, which secrete glucagon, and that's the next common. And then we also have delta cells and other rare types of cells that secrete different products as well. So on your routine H&E stain, there is no difference between a beta cell and an alpha cell and a delta cell. So if we want to identify the population, the cell types, we can use IHC to identify. So here, for example, on the right, what we're seeing are the beta cells being highlighted by insulin stain. And then here on the left side, we have the alpha cells that are staining with glucagon. So you can see here the beta cells, they are predominant, they are more centrally located, and the alpha cells, on the other hand, are at the periphery. Okay, so now we'll look at a virtual slide, and this is where I will ask our residents to participate. Okay, do you see the slide, the virtual slide?
Yes, ma'am.
Okay, great. Okay, so our residents, please, there is no wrong answer. We're all learning at this point. So, please speak up and also feel free to ask me questions. Okay, so here we have a slice of the pancreas. So, this is from a resection specimen. So first question to our residents. So can we identify a capsule here? Yes, no, maybe?
Yes, ma'am.
Yes, ma'am. Yes, ma'am.
Okay, trick question. So the pancreas does not have a capsule. So this is connective tissue. So it is a very indistinct. So do you see here we have some, here the connective tissue is thicker, and then here it's much thinner. So it doesn't have a true capsule, but it does have some connective tissue sort of holding the whole organ in place. Okay, and what are these stromal cells that we see here? These blank cells. Adipocytes. Yes.
Adipocytes.
Yes. And is this normal in the pancreas?
Yes, ma'am. Yes, ma'am.
Yes. Yeah, and the amount of fat increases as we grow older. Or, we have the acinar component actually atrophies. So we have acinar atrophy as we grow older, but fat is always a normal component of the pancreas. And so here you can see this connective tissue. We have these septa coming from these connective tissue, and that separates it into lobules. Now the lobules, sometimes they're not quite complete. Like here you can see that, this is like this whole thing is sort of a lobule, but you also have an incomplete septa coming in right here. So what do we have in these connective tissue septa?
Blood vessels.
Sorry?
Ma'am, blood vessels.
Yes, yeah, exactly. So here you see, we see blood vessels, we see arteries, we see veins. Exactly, we have capillaries, and we also have lymphatics. And the other thing that you will see in this septa are the ducts. And so here I don't have a larger duct, but let's see if we can identify the ducts. Okay. So here we have some ducts. So what do you think? If you had to guess between, so here you have like cuboidal epithelium. So at the smaller end, so where you have the intercalated duct, that tends to be cuboidal. And then as you go higher up on the hierarchy, as you come to the it's going to be, it has going to be columnar, exactly. Yes. So what kind of duct do you think this is?
Cuboidal only, ma'am. Intercalated.
It's an intercalated.
So this is cuboidal epithelium. And so actually, this, do you notice how it has quite a bit of connective tissue around it? So when you have a large amount of connective tissue like that, it's either intralobular or interlobular. So let's see if we can identify a intercalated duct. Intercalated ducts tend to be, they don't have as much connective tissue. So what about this one? Here, do you see it has very minimal connective tissue surrounding it? So that is going to be your intercalated. Yes, so here is a good example. So here, do you see? That is an intercalated duct. So when you're looking at the, you remember your bunch of grapes picture, the stem that is holding the acini or the grape is your intercalated duct. So that's your smallest, and the largest is the main pancreatic duct. And so from each of these lobules, what is the duct that drains each of these lobules?
Interlobular.
Interlobular duct.
Exactly. Very good. Yes, it is the interlobular duct. And so yeah, this is here, yes, interlobular. And here, this one, this is likely to be an intralobular duct. So the intralobular and interlobular, they have a lot of connective tissue. Intercalated has very little connective tissue. Now let's see if we talked about the centroacinar cells, right? And the acini. So here, so what are these pink granules?
Zymogen granules.
Yeah, exactly. Zymogen granules. And what do the zymogen granules contain?
Enzymes.
A few examples of these enzymes.
Trypsin, chymotrypsin.
Yes. Yeah. So remember that. Yeah. So okay, let's back up. So remember that the enzymes that are packaged within the cells, they all have the O gen. So meaning they are inactive. So it will be trypsinogen, chymotrypsinogen. It will only become, so trypsin is the activated enzyme, and trypsinogen is the pro-enzyme, or the inactivated enzyme. So when they are in the zymogen granules here, they're all not activated yet, because if it's active, it'll simply dissolve, right? What are cells made of? They are made of like proteins and sugars, right? So if you have amylase and if you have all of these enzymes that are active, it's simply going to digest the pancreas. So so it's not trypsin, it's going to be trypsinogen, and it's going to be trypsinogen. So inactive enzymes in the zymogen. And then the nucleus is at the base, and you can see that it's very deeply basophilic because of high RNA content, right? It's making all of these zymogen granules, so it's actively transcribing. So that's why it's very, very blue. Okay, so we talked about the acini, we talked about the ducts. What is the other component of the pancreas?
Islets.
Endocrine.
Yes. Yes, endocrine component.
Endocrine.
So
Islets
an
of
islet.
Islets of Langerhans.
Langerhans.
Yes. Yeah.
Islet.
And so we talked about the two types or the distribution of the islets. So when it's oval like this, or a round, cohesive structure, what do we call that
Lightly
distribution?
stained.
Compact. Yes. So here,
Cluster.
yes, cluster or compact. Yes, this is the cluster distribution, the compact distribution. And sometimes, sometimes you also see, particularly in chronic pancreatitis, when you have lots of acinar atrophy, or when you have a relative hyperplasia of the neuroendocrine cells. Sometimes you can see just cords and strings or trabeculae of these neuroendocrine cells. So that is what we call diffuse arrangement. And so here, what are the types of cells in the islets?
Alpha cells, beta cells,
Beta
delta
cells,
cells,
Alpha cell, beta
delta
cell,
and
cells,
polypeptide
delta cell,
protein.
and pancreatic polypeptide.
pancreatic polypeptide.
Yes, excellent. Yeah. So we have different types of cells, but we can't identify them on routine H&E stain. If we want to identify the cell types, then we need to perform IHC to identify the cells. Okay, so do you have any questions about the histology? Anything you'd like to add? All right, that was great. Okay, we will stop the
Pancreatic duct.
slide. Sorry, yes, continue.
Mama, I didn't get pancreatic duct here. Can you
Yeah,
just-
okay. Sure. So the pancreatic, so let me, okay, so here is a really nice example. Okay, so do you see this duct here?
Mom, screen is not showing, guys.
Oh, okay, do you see the slide?
Yeah, mom, thank you.
Okay, yeah. So these are all of the acini, and then acini they look very purple and very pink at the apex. And then here, do you see this is different? This. So
Yeah.
that is your cuboidal epithelium. That is your intercalated duct. And intercalated ducts are the first order of the duct. So the acini makes the secretions, it dumps it into the intercalated duct, which is cuboidal epithelium. Intercalated duct, many intercalated ducts will go into the
Intralobular.
intralobular. Yeah, so here is an example of intralobular. It has a little bit more connective tissue, and then you have many intralobulars that drain into the larger duct, which is the interlobular.
Interlobular. Okay.
Yes, so interlobular, so intra is within the lobule, inter is among different lobules, and interlobular will drain into the main pancreatic duct. So let me go back to my PowerPoint slide. Are you seeing the PowerPoint?
Yeah.
Okay. So here, so if you look at your, think of the grapes, this is your intercalated, like that drains the acinus. Many of these will form the intralobular, and then many of these lobules will be the interlobular. Okay. If there are no other questions, we can stop right here at 7:40.
No question in the chat box, ma'am.
All right, great. Thank you very
Thank
much
you,
for
ma'am.
participating.
Thank you, ma'am.
And
Thank you for
I will see you
Thank
all
you, ma'am.
on Tuesday. Thank you.
Thank you.
Thank
Thank
you,
you
ma'am.
so much,
Thank you
Dr.
so much,
Rani.
ma'am.
It was wonderful. It
Thank
was
you,
just
ma'am.
excellent. Thank you so much.
Thank you so much. Thank you, Munita, for also letting us know what your institution does.
My pleasure.
Bye, everyone.
Thank you. Thank you. Bye.
Bye.
Bye, ma'am.
Bye,
Thank you,
ma'am.
ma'am.
Good night, ma'am.